Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It is a day late. It's October 3rd, 2025. Had a sick kid yesterday and work stuff, so wasn't able to get the pod out on time on Thursday. So today we're talking about something I kind of alluded to a little bit a while back about a landmark in OncoPharm episode. These are episodes where we go back and we look at a landmark study that changed practice at the time. And today we're going to talk about the PARAMOUNT study and maintenance Pemetrexed. This PARAMOUNT, this was published in Lancet Oncology in 2012 in February. The number one movie in America this week in 2012 was something called The Vow, which is a dramatic romance. There's a woman, memory loss. Her husband doesn't remember her. This, of course, stars Rachel McAdams and Channing Tatum. I have no memory of this movie. I never saw it. I do like Rachel Adams and Channing Tatum, though. So anyway, that was what was really big in the culture at the time, was The Vow. So at the time in 2012, in non-small cell lung cancer, we had recently learned in 2009 with the Scagliotti paper that Pemetrexed had performed better non-squamous histology. And this was based off of a study comparing platinum gemcitabine versus platinum Pemetrexed, and no difference in the whole patient population. But in subgroups, we saw a clear benefit with Pemetrexed in the non-squamous cell population, which would mostly be adenocarcinomas as the most common subtype of non-small cell lung cancer and of non-squamous. And so we had learned that, and then we went on to learn this had to do with high levels of thymidylate synthase, one of the targets of Pemetrexed in squamous cell. We had an idea, we knew that second-line treatment with Pemetrexed was better than docetaxel from a tolerability standpoint, same OS benefit. We knew that erlotinib had some data in the overall population. The third line, we were starting to notice around this time that certain people did better. We didn't quite know yet about EGFR mutations. And so there was an idea of switch maintenance. So, in fact, in JCO in 2009, there was a study showing that switching, this was called switch maintenance, where you started maintenance with a different drug in the second-line setting. And this was Lancet 2009. This was a study of 660 patients. 50% of them were adeno. 27% were never smokers. Most of them got cisgem. About a little over a third got cisgem. And maybe about a third got carboplatin paclitaxel, and about a quarter got carbogemcitabine. And they got 4 cycles of chemo. And then they were randomized to either Pemetrexed, which they didn't get in induction, or best supportive care. And we did see an improvement in overall survival that was statistically significant, modest hazard ratio for OS at 0.79. That 95% CI was 0.65 up to almost 1 at 0.95. Now, they only got 4 cycles of induction chemo. There was a meta-analysis in JCO in 2009 of more than 13 studies showing that if you got 3 to 4 cycles of induction chemo, giving more than 3 to 4 cycles of platinum-based chemo, improved PFS, but no difference in OS. And a lot of that probably has to do with it's hard to tolerate platinum-based chemo for a long time. If you can't tolerate the drug, you can't benefit from the drug. So we knew going into the PARAMOUNT study here, this is in 2012, this is published, that the platinum doublet in the past, then switching to Pemetrexed was better than platinum doublet and nothing else. But what we didn't know is if that if you used Pemetrexed up front in your platinum doublet, if continuing Pemetrexed had benefit. And of course, this is going to be something we want to do in our adenos after we know in our large cells, after we have our Scagliotti paper and we learn about Pemetrexed, poor efficacy in squamous cell patients. So that's where we get the PARAMOUNT study here. And so this is a study all of non-squamous patients, because we know that now. 359 randomized to Pemetrexed, 180 randomized to placebo. This is similar to the 2001 Lancet study with switch maintenance, where they were randomized 2-to-1 to Pemetrexed to placebo. If you're trying to enroll people in a study and there's a 2/3 chance you'll get drug versus 1/3 chance you'll get placebo, you can probably enroll patients a little bit faster. These patients are, in this study, are 94% white. They're all stage 3B or stage 4, and 85% are adenocarcinoma. There are no squamous cell carcinomas in this study. And again, about 20% are never smokers. A lot of those patients who are never smokers probably have driving mutations of EGFR and ALK, and maybe others that we know about now, who maybe would not be treated with first-line platinum-based therapy. And of course, this is before our immune checkpoint inhibitors are making their way into non-small cell lung cancer. So these patients are all randomized to 4 cycles of cisplatin Pemetrexed, and they're all non-curable. So not carboplatin, but cisplatin Pemetrexed for 4 cycles, and then randomized to either maintenance Pemetrexed, standard dosing, standard cycles until disease progression, or best supportive care plus placebo. And the Pemetrexed group was also getting, best supportive care here. So you get cispem for 4 cycles, and then either Pemetrexed maintenance or nothing else. And so what we see here is a statistically significant improvement in progression-free survival, which was the primary endpoint. What we see later on in 2013, the final OS benefit or final overall survival data are published, and we see an OS hazard ratio of 0.78, 95% CI, 0.64 to 0.96, very similar to the relative benefit seen in the switch maintenance study. I will point out that the total number of deaths at the time of publication were 71% with Pemetrexed and 78% with placebo. Median OS about 14 months with Pemetrexed and 11 months with placebo. So this was a pretty notable improvement in overall survival in this space. It's not always ideal to look at median OS here because you can skim the mean sometimes. But, our Kaplan-Meier curves separate and stay separated pretty similar here. So I do think it's maybe a reasonable measure of central tendencies, as the statisticians might say. So you see an OS benefit, let's just call it, of 3 months here on average with maintenance Pemetrexed. One of the most notable studies around this same era was adding bevacizumab up front to platinum-based chemotherapy, and that improved the median overall survival by 2 months. And this is a continuing the same drug, so there's no new drug here. You're just continuing the Pemetrexed, indefinitely until disease progression or intolerability. Now, it's a modest OS benefit. It's not nothing, and so there is some OS benefit here. But if you're going to do maintenance therapy, it really does need to be well tolerated. And when we see, and one thing that's always useful to look at is what's the dose tolerance. And there are a couple ways to look at tolerability. You can look at toxicities. You can look at how often does the dose need to be reduced, how many doses are skipped, and the dose intensity was 95% of what the planned dose was for Pemetrexed. So almost everyone's getting their dose on time. And as long as patients on maintenance Pemetrexed are taking their folic acid, getting their B12 shots every 3 cycles, they don't have renal dysfunction, they don't have NSAIDs or other interactions that compete for clearance of Pemetrexed, they should tolerate Pemetrexed pretty well. And we do see this OS benefit and the benefit of Pemetrexed, verified in other studies as well. This is why, to this day, if you have a newly diagnosed non-small cell lung cancer patient or any of these studies coming up, platinum Pemetrexed is the standard of care in our non-squamous population. And that really starts here. It was most solidified with the PARAMOUNT study, but there's more going on to this as well. And of course, then this is kind of, we still see this continuation maintenance happening with immune checkpoint inhibitors as well. So they get their 4 cycles of platinum-based chemo plus an immune checkpoint inhibitor or whatever. Maybe you do 2 cycles of chemo and then nivo ipilimumab. There are several different regimens you can do now with non-small cell lung cancer, mixing and matching your platinum-based chemotherapy. But if they're non-squamous, we're doing this Pemetrexed maintenance because we did see overall survival benefit. So that is the PARAMOUNT study. And this study was, I'll just point out, was the lead author is Luis Paz Arez, who is also the lead author on a study published earlier, I think June of this year in Lancet, of maintenance atezolizumab and lurbinectedin in small cell lung cancer. So different disease state, but I do point that out because we have an FDA approval yesterday of maintenance, of an example of switch maintenance, where you're switching to lurbinectedin in small cell lung cancer in extensive stage disease. So this underscores with Pemetrexed in non-small cell lung cancer, it's continuation maintenance. This approval for lurbinectedin is switch maintenance because you're adding it after your platinum-based chemo. But we'll talk about that probably next week, as well as some other updates as well in the oncology space. But thank you so much for listening and for all your kind words on social media and such. And those of you reach out via email with saying that you appreciate this about the podcast. It's really helpful to keep going, doing this every week. So thank you to all of you who've reached out and the support and kind words. We'll be back in next week with something else. And until I talk to you again, remember, doses matter.